Hello, Assalamu alaikum. Can everybody hear me?
Assalamu alaikum, Dr. Jahar.
Hello, Assalamu alaikum, sir.
Can you hear me?
Yes, I can hear you loud and clear.
Okay. So I think it's
Let's
6
see
o'clock.
if I can. Let me see if I can start video. If I cannot, then I can talk, and we can continue this without way.
So, Assalamu alaikum. How many participants are here? We have 30, and I think they are increasing. So, maybe Sharif, can Dr. Johar start sharing his video? So, Assalamu alaikum. I will just begin. It's already 6 o'clock. And today we have a theme-based session, and this theme is bladder cancer. And we have two invited talks, followed by a nice 1 full hour of case discussion. So the first speaker is our own Dr. Johar Raza. And Dr. Johar Raza completed his residency from AKU in urology in 2011, then went on to do a fellowship in urological oncology, which he completed in 2015 from Roseville Park Cancer Institute in the USA. Then he went on to do a second residency in the US from the St. Louis School of Medicine in Missouri, and he completed that in 2020, and now he's working in the Henry Ford Health System as a consultant urologist. So he's an expert in robotic surgery, and today we're going to utilize his experience, and he's going to talk to us about how to minimize complications during radical cystectomy. So if you're all set, we can start, Dr. Johar. We already have 41 participants. And,
Assalamu alaikum, everybody. Assalamu alaikum, everybody. Thank you, Dr. Razi, for the kind introduction. Can everybody see my screen properly? Because I've got two monitors here, so I just wanted to make sure that you're seeing the presentation here.
Yes, Dr. Johar.
Okay, thank you.
Can one more person confirm if the screen is visible and he's audible?
Yes, Dr. Johar is audible and visible.
Okay, Johar, go ahead, please.
Okay, so I have I don't have any disclosures other than the fact that I haven't done an open cystectomy in the last 5 years. But for the purpose of this talk, because in Pakistan, except for selected areas, we don't have very common exposure even to robotic cystectomy. I've tried to stay away from that part and stress more on what is you're more likely to experience during an examination. And ironically, when I did my FCPS, my long case was a bladder cancer case.
Sorry, Johar, two people are saying the screen is not visible. I wonder why, because it's quite nicely visible to me.
Can they refresh? They may have to refresh their page.
You may have to refresh. Samad Nawaz and Marvi, and in fact, Shua Hassan also says, can you refresh because it's visible now?
Somebody said it is visible. Oh,
yeah, okay, right. Surgery
okay.
Here.
So I've tried to tweak it according to the local population who are more exposed to open surgery and open techniques and what is pertinent to that. But like I said, this is my disclosure that I haven't done one in about last 5 years or so. So what is the easiest way to avoid complications after radical cystectomy? I think the one-step answer or one point answer is stop doing any surgeries. If you don't do radical cystectomies, you will not have any complications, because no matter what you do, a complication-free radical cystectomy is very, very difficult to achieve. Today's talk I'll list some complications which I have divided according to the part of the procedure or the step of the procedure. Among that will be a little bit of a discussion about short-term and long-term. Then I'll look at how can you modify your preoperative factors, intraoperative factors, and post-operative factors to improve the outcomes and reduce your complication rates in patients undergoing cystectomy. When we're talking about complications, I think it's not just the process of taking the bladder out. Most of the complications are related to the fact that what type of diversion you do, what segment of intestine you use, and how immaculate are you with your operative technique. And to be honest, 30 minutes are not justifiable time to capture the entirety of this topic. And for that sake, I've restricted myself to ileal conduit, because probably that's the safest kind of diversion I would recommend anybody to perform earlier in their careers. And it is the one with the least complications associated. So I'll be talking mostly about that, and we'll be focusing on that. And I think the whole idea is, if I would say in the right words, converting the river into a water skin is unjustifiable here. Anyway, so whenever I'm posed, and this was something back in medical school, and I would recommend everybody to follow that. Whenever you're posed with a question, try to categorize your question. And if somebody, and I don't know if these complications categories exist.
And Dr. Johar, some of the participants find the voice low. Maybe you were too much away. Could you?
That's why I was using the earphone.
Okay. Right. So, thank you.
Let me see. How can I change that? Let me see. Is there like?
Sorry for the interruption.
No, it's okay. Let me see. How can I improve the voice? Everything says on. Blah blah blah. Microphone. It says it's on. Does it make any better if I move it up?
The voice is there, though it's only that it's slightly low. The voice is audible.
Let's see. Is it better now? Is it better?
Can somebody who didn't have the voice can comment? Dr. Joh's voice.
Can people confirm if it's good?
Bashir, Mr. Bashir, Dr. Bashir, can you? Yes, it is. Or Zara is saying so. It's good now.
It's good now.
Okay.
Okay.
Go ahead, please.
Sorry about that. I've got two jacks here that I use the other one. Anyways, so whenever somebody is, I think this is what we learned in the medical school, and it is a good way to approach this. If you are posed with a question regarding categorization of anything, complications or indications and things, try to categorize them. It's easier for you to remember whenever you're preparing for an exam, and it basically portrays that you are well prepared and well read. I don't know if the kind of categorization that I've come up here exists in the books, but this is how I've divided according to the steps of the procedure. So what are the complications could be pertinent to radical cystectomy? What could be pertinent to the diversion itself, and what would be pertinent to lymph node dissection? Pertinent to radical cystectomy, you can have anesthetic complications, atelectasis, pneumonia. Patients can have fluid overload. They can get, CHF, myocardial infarction, stroke, and we'll talk about that in a little bit. During the surgery itself, you can have a vascular injury. You can have pedicular bleed. You can have a DVC bleeding. You can have DVT, and we'll talk about how to prevent those. You can have wound infection and wound dehiscence. The key things with regards to wound dehiscence is that you have to have a good closure technique. When it comes to DVC, one alternative could be that you can kindly try resharing screen, Dr. Johar.
Dr. Johar, yes, you can you please reshare your screen again?
Oh,
your slides are not moving actually. Your slides are not moving actually. We can see only the
what are you seeing?
First slide,
please,
initial first slide
first,
actually. Can you share it
Okay.
again, please?
Okay, let me do that. Share this, share. Is it better now?
Not came yet.
yes, it says that started screen sharing.
Sharif, is there, can I share this with you? It's on Google
Sure.
Drive. And then maybe you can run it from there.
Sure,
How about
sure,
that?
Dr. Jha. Sure, Dr. Jha. Please.
Can you tell me your email?
Yeah, sure.
SHARIFF dot
CHARIN.
I got you. And AKUEDU, right? And then I just send it to you. And if you can upload it and I can tell you to change,
Sure.
I think it'll be easier. Or I can try to download it and then run it from because I'm running it from Google Drive. Let me see if I can also. I'm sorry about this technical glitch. Yes.
Good morning, sir. How
I'm
are
in a
you?
meeting. Can you give me like half an hour or so?
Okay.
Is it urgent?
No, it's not.
Okay, perfect. I'll call you. I did download it as well, so as a PowerPoint. So let's see if I can fix that. Hello.
Yes, Johan, you're audible. Sharif, आपके पास आ गई या?
No, sir. I am coordinating with Dr. Jha, sir. Just
Right. So, Jawahar, while the things are being sorted out, can you shed some light on your career after residency here? Maybe you can talk about that for a while. How was it doing another residency after being a graduate of residency here? I think Jawahar is offline, is he?
Dr. Jha is connecting again, sir.
Right. So it would be nice if we could see you, but I think most of us choose to not show our videos, right?
Let me see. You guys can hear me. You can see me. Let me share the screen again. Let's see. Share again. Can you guys see me?
Yes.
Can you see my screen?
Yes.
Yes, now we can see your screen, sir. Click on the full
Can you
mode.
see-
Select full mode.
Can you see the transition? Is that better? Can you see the transition now?
Just
I
click
think
on the
it might take a while. The slideshow, you want to?
yeah
show the
slideshow. Just click on that.
Yeah.
Where? Are you seeing two screens, one big and one small?
Yes, we are saying this this correction mode. Can you click on the slideshow so that we can?
Just click on that slideshow.
End slideshow, show taskbar. Where is the slideshow?
The one.
Click F5. Click F5 on your keyboard, sir. F5 button.
F5. The problem is I have two screens, so I have to check which one I want to share.
The one that, yeah.
Hang on, let me just see. Sorry. Lost all the text savviness now.
We've lost your screen again. Which one were you sharing? Which computer? Yeah. So
the thing is, if I put it full screen here, I've got two screens, so it switches to two screens. Let me run it through this way. I don't have a lot of animations, so you should be fine.
Yes, you can.
Can you see? Can you see the transitions here?
No.
Can you see the transition of slides now?
No.
No.
Okay. You can't see my. Can you see the slides?
No, sir.
Or it says.
Please dial 165-490. Marquita Odom, please dial.
Is this better now?
165-490. Thank you.
It does say you're seeing Johar Raza's screen, but.
Oh, you don't see my thing at all, huh?
No.
Let me just
No.
try. Because.
Can you please share your presentation so I can run from my computer?
I did it. I did share it with you.
Dr. Hammad will join shortly, in momentarily. He's coming over. So somebody says missing Dr. Hammad. He's coming over. He's coming over.
Acha, let me see this. Let me minimize all windows. Then go back. Where do you stop sharing? Sorry about that. The other thing is, if Dr. Shahzad is ready, he can start talking, and I can do it afterwards. Don't want to keep people on hold for no reason.
Dr. Shahzad, are you able to start your talk? देख लें आप 5-10 मिनट देख लो अगर जौहर हो जाता है तो अच्छा होगा. I think
any difference? Can you see something?
No, sir. It still says
started
screen sharing.
Blank आ रहा है पता नहीं. पहले बहुत अच्छा हो गया था जब आप अभी कर रहे थे.
You want me to log in again? Give it a try.
Yeah, I think so.
Razi, do you want me to come in now?
Johar का suggestion था क्योंकि there is some technical problem. Are you able to?
No problem. Ask Johar.
Yep. Assalamu alaikum, sir. Yes, please go ahead.
Acha, so you want?
If Dr. Shahzad is ready, please, he can go ahead, and I'll share my screen again with Sharif, and I can start afterwards.
Right. So maybe till things are sorted out, we can start the second lecture. Professor Shahzad Asad Shahzad is here. He's a professor of urology in SIUT, and his main interest is robotics and laparoscopy, as well as cancer surgery. And he's going to talk about TURBT and new methods of bladder tumor visualization and resection. Sharif, can you facilitate upload of his presentation? Yes, it's there.
So can everybody see it?
Yes. Can everybody see it, please? Please say in the chat box. Yes.
Yes, sir.
And
We
my-
can see your presentation. Yes,
Right.
sir.
Right. So my voice is clear. Is it not too loud, too low?
It's perfect, sir.
Right. Okay. So good evening and Assalamu alaikum to all my friends, Razi, Johar, and others, residents, junior residents, and junior colleagues. So let us talk about something which is not at the very end of the cutting edge technology, that is robotics. Of course, I am just a novice in that kind of a setting. Not much have been done as compared to what Johar will be saying later. But we are trying our best to develop a robotic platform and different kinds of surgeries that can be done with minimally access surgery and a narrow access surgery through robotics. So we can somehow, or sometime later, we can talk about it. So let's talk about TURBT and new methods of bladder tumor visualization and resection. So it is something that is TURBT, which is rather underappreciated sort of a skill, but that is very crucial. That is very crucial in the sense that it gives you a kind of a division between two basic, pathways of dealing with bladder tumors, and that is non-muscle invasive and muscle invasive bladder tumors. What will be the objective of this presentation? We will be talking about transurethral resection of bladder tumor and its challenges, surgical strategy of resection, piecemeal versus en bloc, monopolar, bipolar resection, not much difference in these two kind of electrocauteries, resection of small papillary bladder tumors at the time of TURP, and something later about photodynamic diagnosis and narrowband imaging, which we don't have now in our setup, but we can always think of and start learning about these kind of technologies. So transurethral resection of bladder tumor, it's the first line procedure which is intended to be diagnostic as well as therapeutic, since it provides a specimen which allows the pathologist to determine the stage and grade while simultaneously removing and fulgurating all visible tumors. As we all know, more than 70% of bladder tumors are non-muscle invasive. TURBT is not effective for carcinoma in situ. As we all know, CIS is a flat, high-grade, non-invasive urothelial carcinoma. It can be easily missed or misinterpreted as an inflammatory lesion during cystoscopy, if not biopsied. And if you want to have a higher yield of picking up CIS in your population, then you must get hold of your technique and do biopsies which are random. And we'll see later on how these random biopsies can give you some good results as far as CIS is concerned. So what the guidelines for TURBT say, the guidelines all over the world, they are in agreement that the final diagnosis of bladder cancer is based on cystoscopic examination and TURBT specimen histology. The guidelines further agree that all visible lesions must be resected completely with bimanual examination under anesthesia before and after TURBT, and that adequate sampling is required for proper tumor identification and staging. And here lies the place for further visualization by techniques like PDD and immunofluorescence techniques and other things. Now, TURBT is performed with rigid cystoscope to ensure adequate maneuverability. The position of the patient, as we all know, is a dorsal lithotomy. Thorough visual inspection is then performed using 0, 30, and 70-degree lens. So you got to have a panoramic vision of the bladder in order to have a complete understanding of what's happening and where it's happening. Either it's the dome, the posterior wall, the lateral walls, or it is closer to the neck or the trigon the exact location and extent of tumors should be noted. Now, these are the instruments that we all know. We must be able to know that whenever we want to see the complete picture of the bladder, we must rotate the lens rather than the whole instrument. And if we know how to rotate the lens, then the intelligent use of the lens, of a particular lens, like 30-degree or 70-degree, will give you a better understanding of what's happening within the bladder. Now, the goals of resection in TURBT are to make that correct diagnosis and completely remove all visible lesions, and assurance of an adequate depth of resection inclusive of muscularis propria. And there lies again the advantage which the new diagnostic modalities and newer visualization techniques give you. It should be performed systematically in individual steps to achieve success, and the success, the measurement of the success will be the factors which is assigned closer to the disease risk, which includes primary or recurrent, number of tumor, the size, the multifocality, concern of the presence of CIS, and characteristics like sessile, nodular, papillary, or flat. These are all very important things. If there is anything missing in the mind of an operator, the correct diagnosis and the correct treatment will be missed, and it will be a sort of a misadventure. So the clinical stage, which can be judged by biomanual examination and anesthesia, the adequacy of resection, that is visual complete resection, and visualization of muscle at the resection base. And there again, we will see later on how these newer technologies give us an edge. And the presence of complication, of course, assessment of perforation. Now, histologically, bladder tumor frequently exhibit growth beyond the visible edge. So whenever you are resecting on a visual perception, but you should include the margin which is beyond that growth, maybe a papillary growth. And the margin should be extended, for instance, 5 to 7 millimeter, which is a normal tissue. So a normal tissue should be included along with the tissue which you see as an abnormal, as an abnormal growth on a normal urothelial surface. Resection is typically performed using continuous flow irrigation and resectoscope with bladder only filled enough to visualize its contents. Now, the bladder should be filled like 50 to 70%. It shouldn't be filled 100%. Why? Because the lesion, if it is flat, it becomes flatter. If it is papillary, it becomes again a little bit flat. So it will be an easier sort of a dissection when it is half filled or maybe 70% filled. After resection, all visible tumors should be evacuated, and biomanual examination under anesthesia should be performed. Any palpable lesion should be noted and then staged accordingly. Now, this point that lifting of the tumor edge away from the detrusor lessen the chance of perforation, it can again only be done when you are doing, for instance, a technique which is an en bloc technique. With a loop, it will be rather difficult to just raise the edge and cut, because these are two different maneuvers. You can't do it with one hand. You can't just move the growth up with the same loop and cut with the same loop. So the maneuver is a little bit difficult. But with the en bloc technique, it can be done, and more so with something called Collins knife. We'll see later on at this point, which I'm just telling. So additional resection with cutting loop or cold cup biopsy can be obtained to send for histopathology separately, so as to determine the presence of muscle invasion by the tumor. Alternative to formal TURBT, many small tumors may be resected using the cold cup biopsy forceps, and this is helpful in patients with thin-walled bladder, particularly in females. So here I just show you a little bit of a clip which you are all familiar, but let's start our talk from this clip. You see, whenever you are using the loop, you can use it in two ways, actively or passively, which means a forward stroke or a backward stroke. Now that depends upon the surgeon's capability. Again, you have to know what is your limit. You can't see beyond the growth. So that is something which is actually missing. So it should be in baby steps rather than a single one stroke, because that one stroke can give you sometimes better result, can sometimes land you in difficulty. And then you must complete your procedure by knowing what is the depth of that kind of a lesion. A little bit about the piecemeal versus en bloc resection. Now, when you do a piecemeal resection, always this is a kind of a situation whenever the growth is too big. And it might be papillary, it might not be papillary. But then, since you can't see anything behind the growth, so you have to make yourself comfortable by taking piece by piece the whole growth, rather than taking the whole thing in one stroke. It is not a good method of resection due to very high rate of recurrence of bladder tumor at the resection site, because when you do piece by piece, you always sometimes miss, because many of the times it is the multifocal lesion, it is not a unifocal story. With the en bloc TORBT, what you have is something called a disc, and that disc is actually containing the margin, which is a normal margin, the margin, which is an abnormal margin. In between, there is a growth, and below it, you can have the muscle. So you can have 3 or 4 different type of essential elements within a single piece of tissue. How we can do it? We can do it with a traditional loop. We can do it with a Collins knife. We can have hybrid knife. It can be done with holmium laser or thulium laser. We'll see some of the examples of these things later. Involve the excision of the entire tumor with underlying segment of muscle with the specimen being resected and extracted intact rather than piecemeal. So you must always strive to have a complete extraction of the tissue rather than tissue in pieces, because that will be helpful for the histopathologist to categorize. The benefit of en bloc resection is less cautery artifact and provides high quality resected specimen with the presence of detrusor, as we have discussed earlier on. Shorter hospital stay, catheterization time, less complication, and lower recurrence rate, because everything is just under your vision. The depth of the tissue is just under your knife, the Collins knife if you are using it, or maybe under the loop. So this technique is most feasible in papillary tumors with distinct stalk, but it can also be done for lesions which have got a flatter stalk rather than a very thin stalk. The concept is you have to go behind or beneath the growth, so that the muscle layer is taken, and then you have to lift it up. As I have said earlier on, you have to lift it and cut it with one hand, with one instrument. You can't have the other hand or other instrument just to lift from the other instrument, and then you have to cut. So there is some kind of a maneuver that you have to learn, but then it has got its own importance and benefit and value. We'll see how we can have this kind of situation from this example. Now this is the en bloc resection with the loop. You see, with any burst of the electrical current, it is as short as possible. So you're not moving your instrument in an arc-like fashion, so your stroke is very minute. You are not covering large distances, but then it is very precise, and what you see is what you cut. You don't cut something which you don't see. Since you can't see behind the growth, so you're not going behind the growth. You are just lifting it from the end where you are actually seeing it. So this is the operator's end. Now, the moment you see these crisscross fibers, now this is the plane that you have to just exploit. Now, if you have got a Collins knife, what you do is you get hold of this plane, and by means of the tip of the knife, you just hook it up and then cut. Now, with this arc-shaped loop, this is not possible. So with the arc-shaped loop, the chances of perforation are more as compared to when you have got a knife, a Collins knife. And piece by piece, you go one by one, step by step, up towards the edge where the tissue is actually attached to the very last until everything is just detached from the urothelial surface, rest of the bladder. A little bit of something which is a hybrid knife, how this thing can help us if we have got it. Now, this is a kind of an instrument which has got two things in one gadget or in one instrument. There is a nozzle through which a jet of water or saline can be exited, and a kind of a tip which is a monopolar cautery. So what you do is you make different holes and you just mark your margin of resection. And in between the holes, you just touch the urothelial surface and inject the water. Now that water will just raise the bleb of tissue which is in the middle. Then you connect the dots, and when the dots are connected, the tissue is actually raised. So whenever you see that the tissue is not raised enough, what you can do is you inject a little bit of water more so that it sort of separates from the rest of the edge. It elevates and gives you a kind of a space to dissect within. So this is the actual procedure in actuality. The saline or the fluid is injected and the bleb of tissue is actually raised. So the concept is what you inject is just to raise the bleb of tissue which is in the middle as a nucleus, and it separates from the rest of the submucosa. So the muscle layer is just beneath the 2 or 4 smaller points of diathermy, which you have already done. And then you connect those dots, and the tissue is actually raised to the very edge when it is detached from the rest of the bladder. The quality of resection actually depends upon the presence of detrusor muscle in the specimen, and it is considered as a surrogate criterion for resection quality. On the flip side, the absence of detrusor muscle in the specimen is associated with a significantly higher risk of residual disease, and that goes hand in hand with early recurrence and understaging. Now, there has to be a scheme of bladder biopsies. Now, carcinoma in situ can present as a velvet-like reddish area which is flat, as we all know. It is indistinguishable from inflammation, or it may not be visible at all. So if you've got a higher, say, index of suspicion, then reasonable multiple biopsies should be taken from suspicious urothelium, and that can give you the yield for carcinoma in situ. In patients with positive urine cytology or with a history of high-grade G3 non-muscle invasive bladder cancer, and in tumors with non-papillary appearance, mapping biopsies are recommended. Now, these mapping biopsies of the bladder include those taken from trigon, dome, right, left, anterior, and posterior bladder wall. And then if you have got a kind of a diagram in front of you, you can divide the bladder in different sectors. You take biopsies from different sectors, and that is a mapping biopsy. Now, the energy source, actually, these two sources, monopolar as well as bipolar cautery, they don't have much difference in terms of results. In bipolar, as we all know, the active and passive electrodes are very close together on the circuit. The irrigation fluid can be either sterile water or 1.5% glycine in the case of monopolar at 150 to 200 watts cutting and 70 to 120 watts coagulation power, or 0.9% normal saline in bipolar current at 150, 250 watts cutting and 80 watts coagulation. You must know what what is this kind of a blending of two currents in electrocautery is, because that will give you an edge if you want to have an efficient electrocutting or electrocoagulation in endoscopic surgery. So this is the kind of the loops that we have, the polar and the bipolar. Just a little bit of what the bipolar resection can be done through a bipolar loop. Now this is a plasma kinetic button or bipolar loop, and it's not a loop, it's a button. It has got its own advantage because it has got a flatter surface and just like a coin, and it has got an edge. Now with the edge, you can always have kind of an advantage of raising the tissue, and with the flatter surface, it just acts like a roller ball. So you have got two things in one built-in sort of instrument, and you can do a very efficient and very fast dissection as well as coagulation and cutting. So this is not available in our setup, but it is always sort of exciting to know what's around the corner. So with this, you can have an en bloc resection as well as something which is electrocoagulation of a wider surface if that is the situation. A bit about the laser. Laser coagulation allow minimally invasive ablation of small papillary tumors. The YAG laser, which is like 1064 nanometer non-ablative, has the best properties for use in bladder cancer. But the two competitors around the block are the holmium as well as thulium. Now for holmium, it is a pulsed laser and it is ablative. If you want to have a continuous laser with ablation and non-ablative properties, then thulium is something which will give you the kind of advantage. So thulium is for a continuous laser setting, and holmium is for a pulse mode. The challenges in TURBT, lateral wall tumors, tumors overlying ureteral orifices, tumors located at the dome, tumors in or at the diverticulum. So the lateral wall tumors are difficult to resect and often cause obturator reflex. Obturator reflex is the sudden adduction of ipsilateral leg during TURBT due to direct stimulation of obturator nerve by electrical current transmitted by resectoscope, which runs in close proximity of the lateral wall during its intrapelvic course. Obturator reflex increases the risk of bladder perforation by inadvertent deflection of instruments laterally. Now, obturator reflex can be mitigated by minimizing bladder distension, usage of bipolar current, and by blockage of the obturator nerve. And the latest technique in this setting is, in this type of situation, is a transvesical injection and a block of obturator nerve. So there's an injection which is given transvesical. Now, if there is a tumor which is overlying the ureteral orifice, there is a kind of thinking that we might be able to close the orifice with the electrical current, and there happens a hydronephrosis, which we'll see later on in these kind of patients. Now, if only pure cutting current is used and the resection stroke is as quick as possible, then this effect is minimized, and we don't have to just do stenting of upper tract after the procedure. Now, tumor located at the dome, difficult to resect because of angulation, distance, and risk of intraperitoneal perforation. This challenge is multifactorial and is difficult to overcome. However, some maneuver may help. For instance, minimizing the bladder distension. As I have said earlier on, if you do have a bladder distension, which is like 50 to 70%, then it will be possible to do dissection at the dome. Suprapubic pressure from external site, and extra long resectoscope. Now, these are the things which we all are familiar in tertiary care setup. Now, time should be observed to avoid prolonged cautery because transmission of heat energy could potentially occur to adjacent bowel, even in the absence of bladder perforation. And sometimes we see patients with ileus after TURBT. Now, tumor at the diverticulum, resection of diverticular tumor presents significant risk of bladder perforation, and accurate staging is difficult to achieve because of absence of underlying muscularis propria. Invasion beyond the lamina propria immediately involves the perivesical fat, and it is staged as T3A. Low-grade diverticular tumor are best treated with combination of conservative resection and fulguration of the base, followed by subsequent repeat resection if the final pathological interpretation is high grade. Now, partial or radical cystectomy should strongly be considered for high grade diverticular tumors because tumor can penetrate and can invade extravesically. Now, this is a kind of an example which I want to just show it to you. Now, this is a video clip which is on the public domain by one of our colleagues, senior colleague in Saudi Arabia, Saeed bin Hamri. And what he has showed in this video clip is one of his experiences. The whole bladder is studded with superficial kind of bladder growth. And it's not say one area or one focus, it's multifocal. So what he has done, he has taken a biopsy through a snare, and then he has introduced a laser fiber. And what you can see in this video film is throughout the bladder, he will fulgurate everything which is just superficial and papillary in appearance. When he comes closer to the diverticular, say, diverticulation and the mouth of the diverticulum, there is no problem. The diverticular area is not collapsing. The growth is actually taken care of. So if you have got a situation where you can judge that this tumor is a superficial bladder tumor, and it is studding, and it is present in the bladder in many areas, you can have this kind of an approach to have a relief from a devastating kind of situation where this patient might have hematuria, which is quite troublesome. For anything which is bigger, which is as this one, as you can see closer to the bladder neck, he again considers it to be fulgurated with the same instrument. So this is one of the approaches by which you can have, and whenever you complete your procedure, in order to just make yourself comfortable, you can make use of something called photodynamic diagnosis or something called NBI, which we'll see later on how it can give you the impression and the judgment that your job is complete. A word about repeat TURBT. Complete tumor removal is not always possible. It may be due to excessive tumor volume, anatomic inaccessibility, or medical instability, the risk of perforation requiring premature cessation of initial resection. In the setting of high-grade T1 tumors, repeat TURBT is recommended within 6 weeks of initial TURBT based on the well-established risk of identifying worse prognostic findings or upstaging to muscle-invasive disease in up to 25 to 30% of repeat TURBT specimen. And this is something which is now being addressed in each and every guideline. For instance, in 2020 EAU recommendations, it is said that performing a second TURBT in the following situation after incomplete initial TURB or in case of doubt about completeness of a TURB. Second, if there is no muscle in the specimen after initial resection with the exception of G1 and primary CIS and in T1 tumors. So it has got its own place. Now, what the NCCN recommendations are about TURBT. TURBT is a standard treatment for low-grade TA, NMI, BC. High-grade TA tumors, NCCN recommends repeat TURBT within 4 to 6 weeks if resection is incomplete, or if no muscle is present in the specimen, 40 to 70% of patients will have residual bladder cancer at repeat TURBT. In T1 tumors, which are low and high grade, and of course in muscle invasive disease, NCCN recommends TURBT as initial diagnostic procedure. Now, we often come across something called, whenever we do TURP, there is a suspicion that there's a growth. So whether we should go towards completion of TURP or we should just abandon it, do TURBT first. So what the literature says is only limited data exists on the outcome of incidentally detected papillary bladder tumor during cystoscopy for TURP. Provided these tumors are papillary, small and unifocal, low grade, it seems feasible to resect these tumors and continue with TURP. But that resection of high-grade bladder tumor should not be performed coincident to TURP to avoid tumor seeding and possible intronisation of tumor in prostatic urethra, although the risk appears to be small. So let's move on towards new advancements in TURBT-enhanced cystoscopic techniques. Now, endoscopically, urologists can suspect malignancy based on the presence of visible changes such as tumor or red spots. However, the multi-center study found that 37% of the biopsies performed on the basis of suspicious endoscopic findings resulted in a false negative biopsy. The imperfect sensitivity of cystoscopy, which is a white light cystoscopy, explains the high rate of cancer recurrence soon after complete removal of all visible tumors. It is likely that in many cases, cancer was already present but not visible at the time of resection and simply visible on second resection. So to aid in identification, there is now a kind of a situation where we have got 2 or 3 competing technologies which, if we adopt, can give us an edge. Now, first of all, it is the photodynamic diagnosis of fluorescence cystoscopy. Now, lesion can be missed using white light cystoscopy, and PDD has been developed to assist in the detection of these lesions at the time of resection and thus reduce the rate of recurrence and improve the completeness of resection. Now, what is the obsession of an operator? It is the person cannot see something which is behind the growth, and the loop, if it is used for resection, can have to pass through an area which is actually darker area, which is actually something which is a kind of which is a kind of a situation where we can't see something, and it sort of goes through an area where somebody has to think and imagine there is a normal tissue and there is a space, and after which the person is actually engaging the tissue. We'll see later on how these things actually work. The second obsession is how deep that tissue has to be resected in order to have a margin which is complete, which is negative, which doesn't have the disease. Now, PDD exploits the photodynamic properties of several compounds, including hexaminolevulinate and 5-aminolevulinic acid. These photoactive porphyrins accumulate preferentially in neoplastic tissue, and under blue light, they emit red fluorescence. When blue light technology is used, small papillary tumors in almost 1/3 more cases of CIS, which are overlooked on white light cystoscopy, are identified. In one study, 96% of all tumors were detected with blue light cystoscopy compared with standard white light, and detection was improved for CIS, that is from 95% versus 68% with white light, and papillary tumors 96% versus 85%. This accurately assesses the thoroughness of TUR, and that should be the goal, and again the obsession, and thus decreases the recurrence rate in patients who undergo HAL fluorescence cystoscopy compared with controls. How it is done? 1 hour prior to a planned TURBT, 50 ml of reconstituted solution of HAL is instilled into the empty bladder, and following the installation, Porphyrin accumulates preferentially in neoplastic tissue, producing clearly demarcated red fluorescence with illumination with blue-violet light. PDD has lower specificity than white light cystoscopy. False positivity can be induced by inflammation or recent TURBT and during the first 3 months after BCG installation.
Dr. Asad, sorry to interrupt, but kindly conclude in the next 1 or 2 minutes.
Right. So I need, can I have 5 minutes or?
Okay.
Right. Okay. So this is the white light cystoscopic image of a bladder. And as you go along, I'll just move a little faster so that the point is just stressed. So with the capture of the blue light, the porphyrins are actually seen in the form of a cherry violet red growths. And again, you can have an alternate image of a white light and blue light so that when you resect under white light, you can always see under blue light that your resection is complete or not. For instance, in this image, just to show this image and then I'll move on, you resect the tissue, and in order to see whether you have done it completely, you turn on the blue light and you see that there is a margin which is actually showing you the violet color, and then you resect it a little further. The next technology is the narrowband image. It is nothing but two different wavelengths, two different colors. One is the 4 and 15 nanometer light, which is a blue color, and the other one is the 540 nanometer light, which is a green color, absorbed by the blood vessels, and they give you a kind of a contrast between a normal and an abnormal area, and that has got its own importance in resection. I'll just move on a little further. So this is the image. You see the growth, and you see the contrast between the tumor edge and the normal tissue. Actually, it uses a filter which only emits two lights or two wavelengths or bandwidths, blue and green. The blue stays on top on the superficial vessel area, and the green goes just below it. Both are reflected, and you see later on a kind of a contrast. Right. The third one is the optical coherence tomography. It's the same thing, OCT, which is done for retinal images. Now it is being used in our cystoscopy and TURBT to distinguish bladder tumor from normal, and then it gives you a kind of a diagnosis, better diagnosis. The fourth one is the confocal laser endomicroscopy. Now you can have a kind of a situation where it gives you a magnification of 1300 to 1500x rather than 10x or 40x, and that gives you a kind of a guide by which you can have, under guidance, you can have a better biopsy. It can also be used for confocal scanning microscopy, which does need only two things, Usein and the two normal stains, and immunofluorescence, and it only gives you the topography as well as the tomography of any substance, any tissue which is in front of you, and can give you the result without having a delay of 24 hours or maybe 48 hours. The final one is the SPICE. Again, the same thing. It gives you the kind of contrast between a normal and an abnormal tissue. So thank you very much.
Okay, thank you, Dr. Asad, for a very lucid presentation. There are quite a few questions in the chat box, and while because of the paucity of time, I think if you can respond to these chats one by one, while we start with the next presentation. We are running about half an hour late now.
Right.
So thank you very much. So the next talk is by Dr. Johar Raza, and he's going to talk about how to reduce complications during radical cystectomy. We had a little hitch in the earlier evening when his presentation could not be uploaded. Now we are running it from AKU. So, Dr. Johar Raza.
Assalamu alaikum. Can everybody hear me?
Yes.
And can you guys see not my screen, the screen which has the presentation on?
Yes, absolutely.
I think it's because the hospital does not allow screen share because of HIPAA regulation. I think probably that's what happened. Previously, I had done a presentation from home. Anyways, thank you very much, Dr. Hammad. Thanks for the opportunity. Next slide. I've tailored this talk in order to address the issues more at hand for the local trainee. I don't want to, bombard with a lot of robotic stuff and fancy things, because the ground reality, and sometimes examiners may get upset with that. You want to do robotic surgery? There's no robot in Pakistan. There can be a little bit of an argument. So I've kept that part out of it. I don't have any disclosures other than the fact that my last open cystectomy was maybe 5 years ago or something. So what is the easiest way to avoid complications in radical cystectomy? The easiest and one-step way is by not performing any cystectomies. If you don't do any cystectomies, you will not have any complications, which means that there is no way you will have a radical cystectomy, a complication-free radical cystectomy. But if you are mindful, you can be more involved, and you may be able to avoid complications. Next slide. The summary of this talk will basically, I've composed a list of complications. I've tried to reframe the list of complications based on the various parts of the procedures. I don't know if that classification truly exists in the literature or in the textbooks, but I think it makes it easier. And my recommendation for the trainees or the people appearing in the exam would be to try to categorize. It's not just this complication for radical cystectomy, anything, stone disease, complication of PCNL, whatever. Try to categorize it, and it'll be easier for you to learn and remember. Number two, when you present it this way, the examiner will have this level of confidence that, yes, this person knows what they're talking about. So we'll talk about the list of complications. Then I've divided into what can be done preoperatively, intraoperatively, and postoperatively to get better outcomes. Next slide. So when you're looking at the complications, most of them are particularly pertinent to the type of diversion that you are signing up for. And my recommendation for early starters would be ileal conduit is the easiest to perform, quickest to learn, and is associated with least amount of complications if you follow good principles. When you talk about the complications pertinent to the cystectomy alone, you can further classify into anesthetic or surgical complication. Anesthetic complications are atelectasis, pneumonia. Patients get fluid overload, CHF, MI, stroke. These are the key complications that could be potentially just related to the anesthesia alone. When you talk about the procedure itself, you can have vascular injury, you can have post-operative bleeding, which can be from the pedicle or from the DVC. You can have wound infections, DVTs, and wound dehiscence. These can be avoided by some, paying attention to detail. There is no benefit between using stapler for the pedicles or special vascular sealing devices like ligashore and vessel sealers. But I have seen people use a stapler for the DVC as well, which can be utilized to get a better control of the DVC because of the fact that it's difficult to stitch when you're doing an open cystectomy. Pertinent to diversion, you can have short-term and long-term complications. Short-term complications can be anastomotic leaks, which can be bowel or urine leak. You can have infective complications, which can be sepsis, pyelonephritis. You can get wound infections, wound adhesions could be related to the diversion. Because of the bowel manipulation, you can have ileus, you can have intestinal obstruction, and you can also have GI bleeds in these patients. Intestinal obstruction is usually seen more frequently with patients where you use the small bowel as a diversion segment, versus almost half the incidence of bowel obstruction is seen if you use a large bowel. When you talk about long-term complications, what can go wrong? Now, like I said, I'm focusing more on the ileal conduit. You can have parastomal hernias. You can have a stomal stenosis. They can be metabolic complications. We'll touch on that a little bit. And most of the predominant fact is acid-base dysfunction, renal failures, and subsequent osteoporosis related to that. Additionally, in long term, you can also have ureteroileal anastomotic strictures. These can be primarily ischemic, which could be pertinent to this to the technique, surgical technique, or because of infections, or because of tumor recurrence. So you have to keep that in mind in terms of your list of differentials when you're looking at something like that. Pertinent to lymph node dissection, lymphoceles are very commonly seen. They are formed. These can be infected versus non-infected. Non-infected lymphoceles can be observed, and if they're infected, obviously you need to do pertinent procedures to avoid them or manage them. With regards to vascular injury, that is a big possibility when you're doing lymph node dissection. You have to. One tip is to have a photoproline available on the table. Usually, when you have it available open on the table, nothing goes wrong. When you don't have it, you get a vascular injury. The other thing is the nerve injury. You have to be very cognizant of obturator nerve and the genitofemoral nerve, because these are the two key nerves that you're dealing with when you're doing the dissection. I think the key step here is, especially well, for the obturator, is make some make some blunt dissection and be able to identify where the obturator nerve is. If you follow your landmark and your flow of how you're going to remove your lymph node packet, if you do that, then very commonly you see the nerve in your face, and usually you don't end up with any of these complications. Another complication related to lymph node dissection is lower extremity edema, which can lead to DVT, and we can talk about that. Best thing is, if it's significant, I think compression stockings are the best way to manage this with leg elevation. And for DVT, you give them prophylaxis. Next slide. So what about the preoperative factors? I think this is one of the most critical things, and I think this is where every surgeon has to pay a lot of attention in order to be able to pick the most appropriate patient for this complex procedure. When you're talking about health, general health and nutrition, make sure that they don't have any cardiac comorbidities and things like that, and we'll talk about that in a second. But nutrition-wise, high calorie, high protein diet is highly encouraged now, and we'll talk about with respect to the ERAS is encouraged, and that helps combat the catabolism secondary to the surgical stress. So that should be one of the top priorities. There is recent role of immunonutrition drinks. There are a bunch of randomized trials, and we're also participating in a randomized trial where immunonutrition, especially arginine-based nutrition, is associated with better outcomes in patients who are getting these nutritional drinks. Pre-operatively, before the surgery, I think it's highly recommended that you should improve patients' physical exercise, physical activity, improve their tolerability, their stamina. That goes in their favor. Also, smoking cessation is very, very helpful for improved immediate post-operative pulmonary outcomes. Patients should be taught how to use the incentive spirometer beforehand. You don't have to have the fancy tool. I remember we used to tell patients to hold a tissue paper in front of their face and try to blow it away and keep it straight by blowing out, and that is just a simple maneuver to it's a simple maneuver that you can do for improving their breathing capacity or breathing exercise. With regards to patient selection, keep in mind increasing age, female gender, obesity, overall comorbidity status that you can predict from ASA classification or Charleston's comorbidity index. These are the key predictors of complications. If you have any of that in your patients, you have to be a bit more careful and get a more realistic approach to it. There are preoperative nomograms are available, which you can utilize to predict the morbidity and mortality outcomes for patients undergoing such procedure. Most common ones and easy to use is ASA classification, Charleston's index, Possum score. But more recently, what we are doing, and most of the centers across the United States are doing, and it's online, so anybody can use it, is the ACS National Surgical Quality Improvement Program Calculator. It's an online tool that is available, which can give you and the patient insight into what expectations can be expected. Can you, next slide, please? So this is a calculator. So the one figure on the left is just what it looks like when you're basically when you punch that calculator side in the top bar, and you can compare it on the right hand side. I just used as an example. On the right side, you can see I've populated some stuff to some numbers to give you an idea. So you can just type your radical cystectomy, open or robotic, whatever approach you're using, whatever lymph node dissection you're doing, whatever type of diversion. There are various options that can be utilized there. And then there are patient factors that can be incorporated. So I selected a female patient with 66 to 74 years of age, partially dependent, severe systemic disease from ASA classification, everything else not dependent on the vent and everything. I did add that she's insulin dependent diabetic, on hypertensive medication, has COPD and history of smoking within 1 year, and a height of 65 inches and a weight of 184 pounds. With all this information plugged in, move to the next slide. The NSQIP calculator can give you an idea of the patient's risk, which it says your risk, which is the black bar, which is the red bar, where you stand for the percentage of risk, and also compares it with the average risk that you can see these patients having. So the black bar is the average risk, and you can get an idea that what are the chances of, you can compare with percentages, whether you have an above average chance of having any complications, any serious complications. You can have sepsis, death, DVT, lots of complications can be identified preoperatively. So if you plug this in, you get the estimated length of stay as well. So it's a good predictor of telling you what you can expect in this patient in regards of the outcomes, and obviously tweak yourself accordingly. Next slide. So it's very essential, and I don't need to brag about it because everybody is cognizant of that you have to get your preoperative workup, get more stress on pre-albumin, albumin, make sure that they're nutritionally strong, hemoglobin is appropriately addressed, they've got optimized renal functions. If they have any urinary tract infections, they've been appropriately taken care of. Be careful about neoadjuvant chemotherapy. We are using it more frequently now. I usually wait about 4 weeks after the last dose in order to give them optimal recovery of their bone marrow function. Usually with the dose dense regimen, we are using the bone marrow stimulant as well. So this is not that much of a problem, but like I said, you give them 4 weeks before they're ready for the procedure. Get the cardiac and pulmonary consults, make sure that they are optimized. We do have what we utilize and call it as a preoperative anesthesia optimization clinic. Anesthesiologists as well as medical specialists both assess the patient, identify the preoperative risk factors that can be fixed, and then can be addressed before the patient is ready to undergo surgery. So that is a very important aspect of preoperative planning that we focus on. Then comes the part of the enhanced recovery after surgery, or the ERAS protocol. Based on those recommendations, and I'll give you the quick clips from the Campbell's Urology. The mechanical and antibiotic preparation is no longer recommended, and that is because it's cumbersome for patients to undergo that. They result in more dehydration. There's more acid base and electrolyte imbalance, and there is a lot of bacterial load which is lost, and hence they are more likely to develop pseudomembranous colitis and post-operative bowel issues. I usually keep patients on clay liquid diet for 24 hours. Like I said, no mechanical bowel preparation. Make sure that they get carbohydrate loading, and they can go up to 2 hours before surgery. Now, this is important. Before you embark on that, you must take the anesthesia colleagues on board, because they may not like it, and the patient may have to come back another day for the surgery. So make sure it's a multidisciplinary collaborative effort. Heparin is administered in the preoperative area or at the time of induction. The AUA recommendations are 24 hours of antibiotic prophylaxis, and cephalosporins are adequately recommended. Certain conditions where you want to do it longer, if there is a prosthetic used, I don't know where we would use the prosthetic as such. If there is an external catheter or a prior infection, these are the certain different situations you could use it. There is some data out there that a single dose of diflucan can also prevent some urinary tract infection afterwards in patients who usually patients come with yeast infections afterwards. And then use of NTRK. This is a mu opioid inhibitor antagonist which is used. The benefit of that is that due to the manipulation of the bowel, there is localized opioid secretion, which causes a delay in the bowel transit. And because this compound does not pass through the blood-brain barrier, there are minimal systemic effects, and that helps in the early return of bowel function after the surgery. So these are the preoperative factors that you could utilize to improve your complication rate. Next slide. So as I said, this is the extract from directly from the Campbell's Urology, where it talks about the checklist. This is, I think, tailored according to the urology needs pertinent to cystectomy. As I said, you need to book the case and talk to anesthesia about the ERIS protocol. Make sure that the patient is aware there's appropriate counseling being done. You've discussed the process of no bowel prep. We don't use gabapentin. We just use Tylenol. And then for patient himself, like I said, adequate PO hydration, high protein, high calorie diet is highly recommended. And Gatorade is sort of a Pediasure kind of a drink with high electrolytes and carbohydrates in it, which is recommended for patients to take. And you can take up to 12 ounces before 2 to 3 hours before surgery. Again, we recommend them to take pain medications before the surgery. Next slide. So what are the intraoperative operative factors? Now, I think it'll be a big talk, and it's literally difficult to convert this whole long discussion into such a time-constrained fashion, and that's why I used the to-go diversion of ileal conduit and use that as sort of a marker for people to understand. There are various techniques of doing procedures, various tips and tricks. This is something that I've highlighted, and I would like to explain to you as we go along. So first thing is, whenever you're doing the ureteral dissection, you have to make sure that you have adequate blood supply along with the ureter. So make sure that you have a nice, thick, periureteral fatty tissue available to you. Now, if I can correctly recall my open experience, and this is sort of what I utilize for robotic as well, that there is an avascular, completely avascular plane on the posterior aspect of the ureter. And I remember when I used to do open cystectomies, you would just stick one finger underneath and you could dissect pretty much deep into the pelvis. I think that is the plane I usually utilize to lift the ureter off of the posterior structures, and basically anything around that area stays with the ureter. Number one. Number two, what I see is and with the robot, you get nice magnification. Anything which is running parallel along the length of the ureter, I do not, I make sure that I save that and I do not cut or create a plane between that vasculature and the ureter itself. So leave a nice thick layer of periureteral tissue. Remember that the blood supply coming into the ureter is coming lateral to medial in the proximal part, and as you go distal, it comes from medial to lateral aspect. Left ureter is more prone to ischemia and subsequent problems, primarily because of the fact that you have to swing it over to the right side under the mesentery, sigmoid mesentery, and that can get compressed. Because of more mobilization and you need more length, it can cause, it may be more devascularized. So when it comes to ureterointestinal anastomosis, again, there are many ways to do it. There are tunneling to make it anti-reflux. There's non-tunneling anastomosis. There are Brickers and there's Wallace. Overall, there is no significant difference in terms of complication. The complication rates are similar for Bricker and Wallace, but Wallace is associated with slightly less stenosis in the long run. I personally do a Bricker type of anastomosis. As you can see on the right-hand side, the top picture, one thing that I do is that I take, as you can see, there is a stitch going just below the apex of your spatulation. Again, make sure that you make nice big spatulation and nice big intraotomies in the conduit area. Make sure there is no twist in the ureter. And then I do what I call as a tension relieving stitch, where I just place the stitch, as you can see, close to the level of the to where the apex of the spatulation will anastomose to the edge of the conduit, and that takes the tension off of the anastomosis. And then I use a foromonoclal suture, and then do one interrupted stitch there, and then I do 3 interrupted stitches, as you can see, starting off with the apex of the spatulation to the mucosa, and make sure that it is a good mucosa to mucosa anastomosis. And then after I do 3 interrupted stitches, then I run the anastomosis. Now, I think jury is out. Some people think running can be more ischemic. Some people think interrupted can be more leaky. So there are two camps which favor one over the other. I think it's primarily what you feel comfortable with. I think this is the technique that I've used more consistently in the last few years, and I haven't had major issues. So I'm pretty happy using a couple of interrupteds to make sure that the apical part of the spatulation sits nice and well with the mucosa, and then the rest of it can be laid over the conduit mucosa. The anastomosis is to be performed over soft tubes. If you use the single J stents, 8 French, Celestics, they are very nice and flexible. They stay nice and well. And otherwise, other option is to use double J stents. Usually keep them as like 30 centimeter 8 French. I know when we were doing it open at Aachen, we used to use small feeding tubes, but I think they might be a little stiffer than what I've experienced with the double J and the single J stents. Next slide. Now, ureteroileal anastomosis, and it's very important to pay attention to this, because this is the game changer. To be honest, if you make too small an intraotomy or the anastomosis, you end up with more problems in terms of ileus and swelling and bowel obstruction, stenosis. If there's not adequate hemostasis, you can have bleeding in that area. And the key thing here is make sure that the bowel orientation is not twisted, which can cause ischemia. Now, the picture on the right-hand side is exactly how I do it, except for the fact that I don't use a TIA. I still use the GIA staplers. But I think this is an incorrect picture from Campbell's. It should be anti-mesenteric to anti-mesenteric. I don't know, somehow they have made it mesenteric to mesenteric, which is absolutely incorrect. So you have to make sure that you flip the two ends, bring them anti-mesenteric to anti-mesenteric, and that's when you fire the stapler. I use a 75 stapler. There is no difference between a hand-sewn anastomosis and a stapled anastomosis in terms of outcomes. You can use either one of those. I think that the only difference is that the staple anastomosis is slightly less ischemic, and it takes shorter time. It doesn't take that long a time, but I think it's a sleek skill to learn and know as an open surgeon and as a urologist if you're exposed to it. So and then once you put before you make the enterotomies, make sure that you have light illumination test, and I don't think I need to explain and go into that, but that is something very, very basic, that you have adequate perfusion available in the segment of the conduit and also on the at the anastomotic edges. Keep an eye on your anastomotic edges. If they look ischemic, if they look blue, then that's a point of concern, and make sure that you give it a good look in the end. Once you have placed you have approximated the two bowel segments, make sure you palpate them between your two fingers, and the donut that you feel should be at least 2 finger wide on palpation. And the key thing is to keep water under the bridge. That means that your intestinal anastomosis, ileoileal anastomosis stays above the conduit stays below. It's variable. Some people do close the mesenteric window, some people don't. When I do it intracorporeal, I don't close the mesenteric window. When I do it extracorporeal, I do close the mesenteric window because it's very easy at that time. Then another thing which can prevent you from having anastomotic leaks, have fistulization, all those things, is you should try to avoid irradiated bowel segments if you can. If you cannot and you're stuck with it, then try to cover your anastomosis, especially the enteroenteric anastomosis, with help of an omental wrap that prevents from any fistulization and worsening of your outcomes. Next slide. So finally is the stoma creation. When you're creating the stoma, make sure that first thing that you want to make sure is that you have an appropriate length of your conduit. Don't make too long conduits. Don't make too short conduits. I usually use something around 12 to 14 centimeters, depending on how thick the fascial fat is, the skin fat is. I just tend to err to the side of extra length. I will not talk about how far you need to be away from the ileocecal junction and all that. I think that's basic stuff. When you're making a fascial incisions, just keep it just lateral to the medial border of the rectus, because if you come too lateral, you may end up catching the inferior epigastric vessels. That'd be a horrible complication. Or if you go too lateral, that's when you start having higher chances of parastomal hernia. So avoid that. Now, once you make the fascial incision, you split the muscle, rectus muscle through it, and you put your fingers underneath and allow at least 2 finger breadths of a defect that can easily pass. Make sure it is not too tight, because if it is too tight, you can get ischemia, hence stenosis. Or if it is too loose, it can retract, or you can have a parastomal hernia formation. Once you make a cruciate incision on your fascia, I usually take 2 Vicryl stitches to tag. Pre-place these stitches on the fascia. Then once I've opened the peritoneum, I pull the conduit through, and then on the deepest part of the conduit, I put these fascial stitches so that the conduit stays snug at the level of the fascia. Then, in order to avert the conduit, I use a 3-point stitch to rosebud the conduit. And this is very critical as well, because if you will have a flush conduit to the level of the skin, you will end up having highly more chances of having retraction and stenosis of the stoma and localized skin irritation. So one thing that I tend to do is that I do 4-quadrant stitches, and what I make sure is that if you look at on picture B, if you see the stitches on the body of the conduit, you see them that they are at the same level. So make sure that they are at the same level all around in the four quadrants that you put them. And all you need to do is when you stretch these out, put them on a stay, all 4 of them, and when you stretch them out, it will nicely evert and become a rosebud. You can further rosebud it by placing a right angle underneath this gap, and then sort of just keep scooping the stoma and everting it. And now I'm realizing I did a cystectomy a week ago. I should have made a small video. Probably I'll do it next time and show you guys. And you keep scooping the mucosa in there so that the rosebud forms nice and well. And then when you tie the opposite ends of the stitches so that it remains taut like that. And then you throw a couple of interrupted stitches to approximate the bowel mucosa to the skin edge. So the key factor here is to make sure that you have a nice rosebud sticking out a few centimeters, not too long, not too short again, in order to avoid any post-operative complications, as we talked about earlier on. Next slide. Other complications, other factors to consider when you're talking about intraoperative issues is anesthetic considerations. Now, I have really swayed away from letting anesthesia give tons and tons of fluids. Now, this is primarily because most of the part of the procedure is done robotically. There's not a lot of insensible fluid loss. So there's usually not a lot of, there is not a lot of dehydration. But I categorically mention to the anesthesia folks that do not bolus the patient unless you think he's hemodynamically unstable. Unfortunately, because when we do cystectomy, we cannot monitor the urine output, but there's a lot of data from colorectal surgery where they can monitor the urine output, that if the patients are kept euvolemic, they're not overhydrated or underhydrated, they do tend to do better post-operatively. Along with that, avoid intraoperative hypothermia, make sure the patient is nice and warm. Post-operative pain is an important thing that you need to pay attention to. If you can get an epidural, very nice. If you can get a transverse abdominis plane catheter placement or just a block, that is also a good way to establish post-operative analgesia. Sometimes we end up using what we call as the on-cue pump, which is basically a small celistic tube, which is connected to an auto-regulated anesthetic pump, which delivers the local anesthetic into the incision, which improves the post-operative pain management. At the end of the case, it's important that patients should be on IV ketorolac if the renal functions are acceptable, and IV acetaminophen, which also helps in the pain management. And then again, there are a bunch of checklists. For the interest of time, I won't go through each and everything, but it's important to look into these factors perioperatively in order to improve patients' pain control and fluid management. Next slide. So regarding to post-operative factors, now NG decompression is no longer recommended. I've stopped. It has been long since it has been used. We do decompress the stomach because when we're doing robotic surgery, patients are on Tendelin T-Berg position, steep T-Berg, and that can cause reflux, and that's why we want the NG decompression. We always use it for prostates or any other cases. So we do put an OG or an NG tube, but we take it out at the end of the procedure. Like I said, 24 hours worth of antibiotics is appropriate. You should not extend it for unindicated reasons, because it can only potentiate the problem with post-operative pseudomembranous colitis. Early ambulation and oral intake is an important thing. We usually recommend patients to get out of the bed into chair post-operative day 0 to 1, depending how soon we finish the case. And I think robotic surgery sort of helps with that, but you can still achieve those things if you have good pain control in open cases as well. By day 1 or 2, we encourage patients to be ambulating in the room, or in the hallways, and progressively increase the activity. I remember Dr. Shameen Khan presented some data from use of tracker devices to see how patients are ambulating, and that's a good way to monitoring that, especially post-operatively. And I don't think it's a very, very expensive way to do that at this point in time. With regards to oral intake, I do allow my patients to take ice chips and sips of water on the night of the procedure. Next day, I start them on restricted clears on post-op day 1, which is usually less than 50 cc's of clear liquid diet per hour. If they tolerate it well, they do not have bloating, nausea, vomiting, we progress to unrestricted clears, usually on later half of the post-op day 1 or post-op day 2. Day 2 or 3, if they're tolerating well, progress them to full liquid diet, and then progress them to a regular diet on post-operative day 3 and 4. We do encourage, once they are taking a PO, we start them on PO stool softeners and bowel stimulants. I do give them dedicated rectal stimulation with bicyclical perrectally, which starts on post-op day 1. We also continue post-operative NTREC till the return of bowel function. I'm very, very cautious again with the use of IV fluids. Very, very judicious. Keep an eye on the urine output. Keep an eye on the renal functions. If everything is looking good, we just kind of, as the patient tolerates PO intake, we start tapering off the IV fluids. I usually check CBC basic metabolic panel, which includes creatinine, BUN, sodium, potassium, magnesium, sodium, potassium chloride, and bicarb, and MAG and FOS. And if there is anything that needs to be replenished, we just go ahead and do that. If their patients are doing good and the labs are stable, we give them a lab holiday if needed. We try to keep narcotic pain medications as minimum as possible, and encourage non-narcotic pain medications like epidural, tap locks, Tylenol, acetaminophen, and NSAIDs. I do give Tylenol scheduled round the clock, starting post-op day 1, and NSAIDs depending on their creatinine, and then the narcotics are as needed. We do keep patients on GI and DVT prophylaxis, which is very important, and we'll talk about that in a second. Patients do get dedicated chest physiotherapy and incentive spirometry while they're in-house immediately after the surgery. Next. So this is the checklist, that sort of modified checklist that I tend to follow. Most of the things are similar. Some things can be a little different, but I think I've had fairly good successes with the kind of regimen that I'm using. And as you can see, famotidine and Alvopan is being continued. Chewing gum is needed if I need to put them on, if they have ileus, and we'll talk about it in a second. Next.
Dr. John, can I request you to please conclude in the next 2 minutes? We're running out of time.
Sure. So post-op ileus, if there's a Memorial Sloan Kettering definition, solid food intolerance at post-op day 5, and bloating, nausea, vomiting, and need for gastric decompression. I hold off the PO intake, encourage chewing gum, mobilization, continue rectal stimulation, switch to maintenance IV fluids, and maintain their electrolytes and minimize narcotic use. I get an abdominal X-ray if he needs NG decompression, I proceed with that. But by day 3, if things are not improving, if patient is febrile or has white count, I go ahead and get a CT abdominal pelvis PO and IV contrast if needed. I initiate TPN on day 6 of being NPO. Next slide, please. So, this is sort of a conclusion of the hospital stay. If the patients, my discharge criteria is if they're ambulating with adequate PO pain control, tolerating at least 2 meals, regular diet meals, have had a bowel movement, passing gas, blood work is normal, stoma teaching has been taken care of. They are discharged home, NSAIDs and Tylenol. Levaquin or Lovenox or Eliquis can be used for 30 days for DVT prophylaxis. I've switched to Eliquis. I think it improves post-op compliance with these. Then I follow them in 3 weeks, where I remove the stent, do a path discussion, and check their electrolytes. Next. Now, the ERAS protocol does talk about hydration and everything at home. I think even in this setting that we are currently in, it may be a little cumbersome and difficult to manage, but I think if it can be established, it's a good idea to keep that in mind. So after discharge, common reasons why they come back is because of dehydration, infection, constipation, and small bowel obstruction. except for adequate PO intake for fluids, preferably over solids with short frequent fluid intake. I don't think there is anything especially that you can do for infections and small bowel obstruction. Make sure they're taking their stool softeners to make sure that they're having regular bowel movements. With regards to, and then we check internal renal functions and obtain imaging if there is any concern. If there is hydronephrosis with renal function, abnormal renal function, we rule out reflux with the lupogram. And if there is no reflux, then obviously there is a concern for malignant or benign stricture. Metabolic complications, you can expect acid-base imbalances, and I think this is something patients should, examinees should know. That diversion type, continent versus incontinent, the type of segment used, the length of segment used are the predictors. If you use colon, you can have hypokalemic, hypochloremic metabolic acidosis. And I think in the bold, you can see that there is one thing will be high in each type of urinary diversion. For colon and ileal conduit, your chlorine will be high, which will not be high in any other diversion. So you will have hyperchloremic. In stomach, you will have high pH, which will not be high in any other diversion. So it will be metabolic alkalosis. And if you use jejunal segment, which is very, very rare, you will have hyperkalemia, which should not be present in any other type of diversion. So these are the key, cheat points that you can use to remember the complications, which I'm pretty sure will be asked. Because of the acidosis, patients end up demineralizing their bones and develop osteoporosis in the long run, which has to be corrected with correction of acidosis and vitamin D and calcium supplement. And everybody knows about the vitamin D12 deficiency, although it takes a long time. But if it is clinically evident, you should treat it even if the blood levels are normal. Next. So in conclusion, complication-free radical cystectomy is only a dream. Don't expect that you'll have zero complications out of radical cystectomy. Anything anywhere will happen, and you have to be prepared for it. You have to make good proper patient selection. A good experienced surgeon or a center yields less complication rates, and an average is about 10 to 12 cases a year. If you have a good surgical technique right from the beginning, and the key for that is to make your plan. Whoever is your mentor, discuss it with them, make a plan, and make that step-by-step approach so that you do the same thing over and over again, and the chances of error are bare minimum. Choose the optimal type of diversion, which I think is ileal conduit. Don't be fancy with other types of diversions. If you can create a structured care pathway with multidisciplinary team approach, I think that would be a key predictor of success. And we already know from the ERAS protocol and everything. I think there is a strong research potential which exists which is present in the developing world, where we can use alternate, more cost-effective management pathways to make this more affordable for the developing world, and hence improve the outcomes. And I think there's more research that can be employed in that. Next. Thank you very much for the opportunity, Dr. Hammad, and the rest of the PAUs and the committee. The picture on the left is I did a robotic cystectomy with bilateral cutaneous ureterostomies. So we did the ICG, indocyanine green, which lights up when you use the Firefly, and tells you good vascularization of the segments. So that is one alternative that can be used with fancy equipment, laparoscopy or robot. You can even use it in open, but you need a specific camera. And on the right is the Henryford downtown campus. Thank you very much.
Thank you, Dr. Johar. I think you've comprehensively covered, and for the interest of time, could I request you to kindly go to the chat box and address the queries that the residents have raised on pertinent to your presentation. We have to quickly move on to the next session. Unfortunately, the whole sessions have been delayed for over 40 minutes. So I'm Dr. Ahmed Bashir, who is our PGY5 resident in urology, is going to present the real life cases that we have had, and we are fortunate that we have Professor Prem Gyawali, who is an ex-professor of the TUTH in Kathmandu, and he is a transplant surgeon as well as a urologist with an interest in oncology, and it's a pleasure to have him. Dr. Johar Raza, you have just heard, he is going to be in the panel along with myself. So Ahmed, without further ado, please carry on with the first case. Could I request the panelists to keep their camera open so that there is some interaction with the rest of the crowd? Plus, please keep typing your questions as they come to you. Do not wait for the end of the presentation, and we'll address your questions and queries.
Right. Good evening, everyone. Thank you for joining all of us. I am grateful to Dr. Hammad for having given me this opportunity to present some cases. We have 4 cases in this session. However, let's see how much we can cover in the allotted time. So these cases, we'll try to keep them interactive. Residents, be ready with your chat boxes open. And without further ado, let us proceed with case number 1. Right, G. So the case number 1 is of a 70-year-old male. He's married with 5 children. He's a known case of hypertension, which is well controlled. He is an ex-smoker, an ex-heavy smoker, and currently he resorts to electronic cigarettes. He is functionally ECOG 1. Now, he presented to us with a history of hematuria, which he had in November 2020, right? So he had an ultrasound back then at an outside facility. That ultrasound did reveal an irregular wall thickening at base of the urinary bladder. Now, a very common scenario that happens in a lot of our settings, he resorted to Hakim medications, homeopathic medications, and according to him, he reportedly improved. But not to our surprise, his symptoms eventually recurred. He developed hematuria again, and that is when he sought medical attention. Before coming to us, he already had undergone a TURP plus a TURBT plus a left-sided DJ stent insertion, which we assume was owing to the proximity of the growth to the left UVJ. And this was in this on the 17th of Feb. So this is quite a recent case. His histopathology came out to be poorly differentiated adenocarcinoma. So this is where my first question to the trainees is, you see an adenocarcinoma in the bladder, what are you thinking is the origin? Right, so Dr. Zahra Kazmi has lightly so labeled urachus. Dr. Anil thinks it can be something from the CA prostate. Urachus again. Right, so this is the first person and it's probably the 6th answer that has come from Dr. Niaz Mohammed that says METs. Right, so pretty much the question remains, is this primary or is this a metastatic lesion? Right, G. So when this patient presented, he also had a CT scan contrast enhanced with him. Let's look at the images of these contrast enhanced CT scans. This is following his TURBT. And this is following the insertion of DJ stent 1 month approximately after his intervention. So on the left side, you can see the image and you can appreciate the polypoidal broad-based growth towards the base of the bladder. A corresponding axial section reveals the same findings of a broad-based growth, maybe 1, maybe 2, in the contrast enhanced images, both axial as well as coronal. And this is what was reported. It was, like we said, a polypoidal lesion. It was also involving the left UVJ, which makes sense for them to have inserted the DJ stent. They did point out some multifocal tiny pleural-based nodules, suggestive of METs, but too small to characterize. One finding of note and of concern was what they reported on the vertebral body of S1, in which they said there was sclerosis, hence possibility of skeletal METs could not be excluded and bone scan would be recommended. However, there was no significant regional or distant lymphadenopathy suggestive of metastatic disease. So, further plan of action. Dr. Johar, would you like to comment how you would proceed in this case?
So, can you hear me? Okay.
Yes, we can hear you.
So So you do have, can you go back to the CT findings one more time? Sorry. Right. So I think there are a couple of factors to consider, like differentials have been mentioned. This can be also a variant histology of urothelial carcinoma as well. Urothelial carcinoma with a adenocarcinoma variant. And again, the possibility of pure infiltrating can also be present. Now, given his age, I would also be interested in looking at his PSA level, and also, within the examination, I would like to see what his rectal exam finding is.
Right. So rectal exam
from that
unremarkable in
standpoint.
PSA within normal limits.
Right. So so this is post-resection CT, if I'm not wrong, correct?
Yes.
So what I would do is I would go back and re-resect him,
All right.
and do a complete resection, and
All right.
and to see me, it seems like that you don't have any pelvic lymph nodes on the CT, and you don't have any you have subtle pulmonary mets, so you could argue doing a PET scan if need be. And once your pathology is confirmed.
Wonderful. Thank you, Dr. Shor. That's
Okay,
exactly
so
what.
sorry, Ahmed, to clarify a few things. The important thing when you have a diagnosis of adenocarcinoma, it's an adenocarcinoma, right? Now, adenocarcinoma of the bladder is urachal and non-urachal, or it could be metastatic. We know that the bladder origin is from the same origin as the hindgut. So embryologically, there is a possibility of having an adenocarcinoma, which is showing histopathological features, which is in relation to the epithelium of the hindgut. So immunohistochemistry plays an extremely important role in further diagnosis. Prem, you have any further comments before we move on?
Yeah, Ahmad, good evening, sir. Good evening, Pakistan. We are already 8:45 in Nepal. Anyway, just I'm wondering why few residents, they are thinking about the CA prostate and they are asking PSA. What is their logic? Why they are going toward the PSA? Are they thinking it is carcinoma of prostate? I wanted to ask the residents who rose the questions. Why they are thinking it may be CA prostate?
Yeah, I agree with you. I mean, the diagnosis is quite straightforward. The PSA staining is very clear on adenocarcinomas, and it is unmistakable. They are two different pathologies. I agree with you. Okay, so Ahmed,
Dr. Anil Sai from Nepal is telling that TURP and TURBT was done, and he is thinking the adenocarcinoma is from prostate. No, while you do the TURBT and TURP, you send the prostate chips separately and bladder tumor chips separately. So do not confuse that they have mixed all the chips and sent together. Dr.
That's
Anil,
correct.
it is not that.
Agreed. Thank you, Dr. Prem. So, right. So further plan of action, like we said, Dr. Hammad, this point, it could be primary or it could be metastatic. So obviously we need to reach a diagnosis. We need to narrow down to our diagnosis using further investigations. Adenopathologies primarily.
Dr. Ahmed, I have one question. Sorry for disturbing you. Did you say what was the base? Was there the muscle involvement or not? I missed this portion.
No, Dr. Prem. There was no comment on the muscle. There was no comment on the muscle that the histopathology was brought to us. Right. So further plan of action. Obviously, this patient needed extensive GI workup to rule out any metastasis from the GI tract. So we went ahead, we did a colonoscopy on this patient. The colonoscopy, much to our relief, was normal. And this was on the same day accompanied by an upper GI endoscopy. Now, this is where things start to get a little interesting, because if you look at the center of this table, the body of the stomach it showed some hemorrhagic gastric erythema. However, there was a small area of irregular mucosa seen at the posterior wall of body, and biopsies were taken for histopathology. And now in our minds, probably most of us are now inclining towards whether this is a metastatic disease. At the same time, the oncologist had requested a PET CT on this patient. Now, the PET CT, the axial image, you can see the avidity in the bladder, and towards the base of the bladder, you can see the increased avidity of it, corresponding to the area of growth of the CT scan that we initially saw. If you were to compare it with the coronal section, this section, however, I only included just to show you how quiet the rest of the body looks, especially the lung fields, about which a query was raised earlier. Now, however, this was also picked up on the PET scan. What is this? Would anyone want to take an educated guess in the chat box?
Okay, while they are typing, please carry on. Let's see what answers come. So just remember the anatomy. What exists in this area? Parotid, very good.
Very good.
Environment.
Right. So this is the left parotid, as rightly pointed out by Dr. Anwar. So now this further complicates things. And like we said, these were the only reports that were picked up. The parotid lymph node, the demonstration of the thickening of the base of the bladder, and too small to characterize pulmonary nodules. At the same time, based on the first CT scan that we saw and the query they had raised on the sacrum, a bone scan was also obtained, and that was negative. Now, where do we go from here? We were thinking about a primary urachal. However, we found a biopsiable area in the stomach, and we found a parotid lesion. Where do you think this is going? One of the panelists.
So what you have is a suspicious lesion on a PET scan in the parotid gland, and you have obviously tumor in the bladder, and the rest is quiet. The PET scan is quiet. So you need to know what is happening in the parotid. Are we looking at two pathologies? Are we looking at an odd metastatic deposit? So that is interesting twist.
Yeah, it's very interesting because either it's the bladder metastasized to parotid, very rare, or vice versa. And urachal adenocarcinoma, usually they are at the dome area, not at the base of the bladder. So that kind of puts you in the non-urachal.
Right. So of course, we have to chase our GI pathology that was done. As Dr. Johar earlier pointed out, he would like to confirm the bladder pathology because there's significant amount of growth there despite the post-surgical status. And what is the etiology of the parotid lymph node? So we proceeded with the TURBT of this.
Sorry, Bashir. Quick question. Is this just a lymph node parotid, or is the parotid gland itself?
It is the parotid gland itself.
Okay, thank you.
Right. So bladder neck growth. So visually, we saw a bladder neck growth rising from the anterior bladder wall, and there was also a growth near the left ureteric orifice creeping towards the bladder neck. Dr. Hammad, would you like to recall what you visually saw when you put in the scope?
So here is earlier TUR outside AKU, outside our institution. And when I scoped him, he had a partially resected prostate. There was hardly anything done on the prostate, to be honest. Maybe they have taken a biopsy or so. And obviously his prostate didn't require any resection because his flow is fine. So the tumor itself was close to the posterior wall, left lateral wall, around the ureteric orifice, and almost encroaching on the trigon. So there was a significant amount of tumor left, and we completely resected the whole visible tumor, and we have taken deep biopsies as well during this resection.
Right. So till now, we had quite a few histopathologies to chase. So the gastric histopathology was back, and now we have this. findings consistent with the low-grade B-cell lymphoma with features favoring extranodal marginal zone lymphoma. We have the bladder pathology with us that we ourselves have resected, and this is in coherence with the outside pathology. However, immunohistochemical profile ran in detail just led us to the conclusion that it can be seen in primary bladder or as well as primary GI. So that did not, that histopathology immunohistochemical profiling only made it more confusing for us. To make matters worse, the FNA of the parotid that was done, instead of revealing a pathology, it only landed us with some necrotic material with lymphocytes. So now we're standing at the same spot, we're losing time. Mind you, all of these things take time. Histopathology reports take time, 7 to 10 days on average, maybe even 2 weeks. And we're standing at the same position where we still don't know what the parotid lesion is. Okay, if I find we've reached the diagnosis of the bladder pathology being correct. However, we also have this lymphoma now to deal with. So moving on, does anyone want to comment here? Does anyone want to comment on the peculiarity of the case?
I would like to tell for the residents, probably Dr. Hammad also will add, for the residents, this type of the cases are very, very rare. You'll see in your whole life 1 or 2 cases. In my practice in last 25 years, I have not seen a single case. So residents, don't be confused. It is not very common. Mostly you have the urothelial carcinoma from bladder, but you have in the back of mind that it can also happen. But it is not a very common pathology for the residents.
I think you're absolutely right, Prof. This is something that you don't see every day. We have had quite few adenocarcinomas and quite a few urothelial cancer with aberrant histology, with micropapillary and squamoid differentiation. And I think we have reported this some years back in the Korean journal. Mavish did it. So yes, you're right. Urothelial cancers is what you see with sometimes aberrant pathology, but adenocarcinomas are relatively rare.
Right. So I see a few comments in the chat box still on adenocarcinoma of the prostate. Just to remind everyone, prostate was sampled at the outside facility. It was sampled again at our facility, both separately, which did not reveal any primary malignancy of the prostate. So however, we had no choice but to proceed with the parotidectomy under ENT care. And this parotidectomy then revealed the lesion, which was consistent with Warthin tumor. Now, obviously, specialists have to be involved. You have a diagnosis of a lymphoma and you have a diagnosis of a Warthin tumor. I'm sure most of the residents would not be well aware with a Warthin tumor or how that small lymphoma would behave. So much to our reassurance and relief, the case was discussed in the multidisciplinary tumor board where we had all specialists present. It was concluded that the lymphoma, being that small and being low grade, did not have the potential to cause what we saw in the bladder. Number two, that lymphoma could be left as it is only on surveillance as per a general surgeon or an oncologist. The parotid gland pathology, again to our relief, a Warthin tumor is the most common benign tumor that we find in the parotid. Hence, there was no evidence of invasive malignancy, hence no further treatment or follow-up was required. So after running around in circles in the maze, do we finally have a complete picture, Dr. Hammad?
Okay, so so far we know that this is an intestinal type adenocarcinoma, and as I've said that because hindgut and the bladder share the same embryological origin, intestinal type adenocarcinomas can be primarily seen in the bladder. All our workup so far indicating that there is no metastatic disease and there is no even locally advanced disease. So this is a primary adenocarcinoma of the bladder, and the rest is pretty straightforward. So the resident should vote now. The idea was not to really tell you that this is what you may end up seeing in your final examination. The idea is to show you how complex the oncological diseases are and how you can make sensible decision with a multidisciplinary team meeting or a tumor board, whatever you like to call it, Europe versus North America. This is really a disease which should be treated by multidisciplinary approaches. So that's the key. The rest is, he's admitted he's due for surgery tomorrow. Very keen to have an orthotopic bladder. We'll see his paracollicular biopsies have been negative. So hopefully he would have a radical cystectomy, pelvic lymph, and maybe an orthotopic bladder. So I think we can move on to the next case, Hammad. Prem,
Yes.
do you agree with this plan?
I agree with you, Dr. Hammad.
Thank you very
It is
much.
very
Jawahar?
complex case.
Yeah.
And you should also tell the prognosis of the urothelial carcinoma and the adenosine carcinoma. The prognosis in the both cases are very poor, and even more with the adenocarcinoma.
You're absolutely right. The adenocarcinomas and squamous cell carcinomas are really disastrous diagnoses compared to even high-grade or invasive urothelial cancers, and the prognosis is quite poor. One of the major reasons is that there is no adjuvant treatment. I mean, you have so much available for urothelial cancer in terms of adjuvant or neoadjuvant treatment. There is nothing which is available for adenocarcinoma and squamous.
You are right. You are correct.
You're right, absolutely, Professor.
Yeah, I agree with your plan, Dr. Hammad. Multidisciplinary approach. And I think one thing to highlight here is that 30% of the community urologists miss the divergent histology. And that's why they are underreported. So that's another key factor that that has to be kept in mind.
So, Dr. Jawahar, we lost your voice, but I think he's making a very good point about the aberrant pathology with urothelial cancers.
Yes, what I meant to say was that patients can end up, the pathologist can end up incorrectly diagnosing variant histology. So that's known in literature.
Hammad,
Right.
I think you can carry on.
Yes, I'm going to move on to the next case. I think Dr. Hammad may have lost audio momentarily. However, let's proceed with the next case. Now, this case is of a 69-year-old male. He's a known case of hyperthyroidism. He's a known case of atrial fibrillation, which was recent onset within the last 2 years of presenting to us. And he was a known case of advanced chronic obstructive pulmonary disease, so advanced COPD, AFib, and hyperthyroid. His COPD was so bad that over the last 2 years, he had admissions for spontaneous pneumothorax ×2. And both of the times, he needed chest tubes under care of cardiothoracic surgery. So even though he was ECOG 1 or 2, because he was still managing most of his restricted activity himself, he still had some pretty debilitating and serious comorbid conditions. The other thing that was very pertinent about this case was this gentleman belonged to a very resource-poor family. He was a sole earner on daily wages. And I mean, all of us now understand how much of a stringent follow-up any case of bladder cancer requires, be it non-muscle invasive or be it muscle invasive, and obviously everything requires a lot of cost. So it's a lot of burden on the patient to meet all the deadlines when we're talking about BCG, weekly induction regimens, and then maintenance regimens, and then cystoscopies in between, and re-TURs. So it's a lot of financial burden on patients, and to manage that in a tertiary care hospital in a third world country can be quite challenging at times. So with this prequel, let's move on to his story, not just his history. His story started back in August 2020 when he had at an outside facility. He had a TURBT. That TUR, so he literally presented to us with that small card that showed that he had undergone a TURBT and a handwritten histopathology, which we weren't sure if this was written. So for us, it was a query T1 high grade plus carcinoma in situ. This is what the histopathology said, and we're talking about sometime last year in August. Surprisingly, he had then been put into mitomycin times 4. After 4 sessions, he had decided to seek a second opinion. We don't know if that was on anyone's recommendation, but that is when he landed up with us. With the CT scan, we don't have the images. However, it showed gross extravesical disease with an enlarged lymph node. It wasn't a good quality CT scan. It was just one film. However, this is what we concluded. So again, this was a query. The histopathology for us was a query. The CT scan was also a query. Now, Dr. Johar and Dr. Prem, since both of you are not in Pakistan, how much of mismanaged bladder cancer patients do you guys get to see in your settings?
It's a little difficult to see absolute mismanagement here, but you do occasionally end up with things which are inappropriately managed. I think primarily it happens at the level of inability to perform a resection for high-grade T1 and things like that. Otherwise, I think with a good support system, as long as you're insured, you do get appropriate standard of care followed based on the guidelines. So if you're not insured, you are as equal to as this poor gentleman.
Dr. Prem?
Yes, sir. Here I'm wondering how the pathologist could write if it is carcinoma in situ and they are making question it is high grade. Carcinoma in situ is always high grade. You should accept it. And I couldn't get this regime of the mitomycin for 4 cycle. Which guideline says the mitomycin for 4 cycle?
So this was a case of poorly managed or mismanaged bladder cancer.
Okay.
Definitely not following guidelines.
You mean then you should go from the very beginning. You should keep it just like a first time visited patient. And if the CT scan says PT3B, then definitely you should have the base of the tumor. You should see the muscles. CT scan radiological, it can say 3B, but you should prove it histopathologically. If it is T3B, then you should go for the radical treatment and go accordingly.
Right. That makes sense. So for now, we're not sure of anything. We only have a case of mismanaged bladder cancer from outside.
You should start from beginning. You should tackle just like a patient came first time, and you should start from the beginning.
Agreed. So
my quick question, Bashir, is what is his symptomatic status? How symptomatic is he? What are his symptoms at this point in time?
So gross painless hematuria on and off, but nothing that is requiring emergency visits for clot retention, nothing that is requiring hemoglobin drops, no flank pains owing to any hydronephrosis potentially. So no real symptomatology apart from hematuria on and off, which he is pretty okay with living.
Okay, sure, go ahead.
Right. So just like Dr. Prem mentioned, we took this as a fresh case. We took him back to the operating room and we did a TURBT on this gentleman. On scoping, he had a broad-based necrotic growth, approximately 3 centimeters in size at the left anterolateral wall. His scar site, probably from the previous resection site, was visible on the posterior wall. So they may have cleared out that site well. However, this was a growth away from the previous site. this histopathology came out to be T1 high grade. T1 high grade histopathology, and none of the bladder mucosa exhibited signs of any carcinoma in situ concurrently. So basically at this point, just like Dr. Prey mentioned, you forget the initial mismanagement that took place. You have a straightforward case of T1 high grade. How do you proceed from here? Residents.
So I think we need to clarify a few things before the residents start talking about this. The first and most important thing is to remember that anything which is CIS, anything which is high grade, is not for intravesical treatment with chemotherapy. So chemotherapy is always out, and the only treatment of choice is BCG. So it's always also important to remember that the timing is extremely vital in the management of bladder cancer. So if you have missed the boat and patient develops high-grade therapy, high-grade disease, they may likely to develop metastatic disease, and this is something that you need to be careful about. So for residents' perspective, take-home message is that T1 high-grade disease or TA high-grade irrespective, and CIS, they are not for intravesical chemo, they are always for intravesical immunotherapy with BCG.
Right. So as rightly pointed out by a lot of people, we began with the BCG induction. 6 cycles.
Can you tell me again, what is the muscle involvement in this case?
No muscle involvement. It is confined to the lamina propria.
So did you take biopsies from the old resected area, where the scar tissue from old resection site? Number one. Number two, what happened to that T3B and 1 business? Like, did you do any other scanning, any imaging? What happened to that?
Right. So no, Dr. Jha, we did not proceed with any scanning. We wanted to first establish the histopathology because the outside histopathology was both unreliable and did not make a lot of clinical sense to us. The CT scan was a one-off film which was suggestive of T3B disease. It was a query for us. We took it up as a fresh case. We wanted to establish the histopathology first and then take it from there. So, and on histopathology, this was clearly a non-muscle invasive bladder cancer, which was high grade.
Right, which was in a different site than the original resection. But that's another thing. What was your personal impression of the CT scan? Did you think that this was T3B N1?
Dr. Hammad, would you like to?
Important, I think the important thing to remember is that TURBT is a pretty invasive surgical procedure. And there is always perceptible, imperceptible extravasation following TUR. So even a biopsy, you should wait for 2 to 4 weeks to do a scanning. If you do very early scanning, you may have an artifacts around the area of resection, which can be construed as locally invasive disease. So I think in this situation, exactly that's probably what has happened. So the lesson to the resident is that either if you have a high degree of suspicion that this is invasive, muscle invasive cancer, do your CT scan prior to, but in most situations, wait for at least 4 to 6 weeks for all the extravasation to settle down before you do CT. What's your policy, Prem, about doing CT scans for?
Dr. Ahmed, same question I was going to ask you, but you aheaded me. In Nepal, what is our practice is that we do not do CT scan in each and every cases. Yeah. If in the ultrasound, the tumor size is bigger than 3 centimeter, it is EORTC guideline. If the tumor size is bigger than 3 centimeter, only in that case, we subject the case for the CT scan prior to TURBT. You correctly said, if you do the CT scan immediately after TURBT, definitely there will be some reactive inflammatory process around the bladder wall, outside the bladder wall, which can mislead you like just like a T383B, or the tumor has gone beyond the bladder wall. It may confuse your diagnosis. It may not be exactly correct. So if in our protocol, if in ultrasound, if the bladder tumor is bigger than 3 centimeter, we do CT scan prior to TURBT. If it is smaller than the 3 centimeter, we go directly for the TURBT, and we do send the bush of the tumor, the base of the tumor, to separate sample for the histopathology. We must see the muscle layer there. If muscle is involved, then definitely you should go for the radical cystectomy. If there is no muscle involved, then after 2 to 6 weeks, between 2 to 6 weeks, we do go for the re-TURBT. Re-TURBT is also now a very popular procedure, because we may miss the tumors, we may miss the stage of the disease. So in Nepal, we practice to do the CT scan if the bladder tumor is bigger than 3 centimeters.
Perfect. So there is in the chat box, I see a question about the RETUR, and Professor Gayawali has already explained the RETUR. Now try and understand the philosophy of RETUR. The philosophy is that if you have a high-grade cancer and your initial pathology has shown a T1 or TA disease, and your muscle have been negative, there is still a possibility that you may have missed out a muscle invasive cancer. Now, if you treat this patient with intravesical treatment, the next time that you go in and do a cystoscopy and a biopsy will be close to about 2.5 to 3 months later. 6 weeks of induction BCG, about 2-3 weeks, you let the BCG effect go away from the bladder, and then you do your cytologies, and then you do another cystoscopy. So if you miss that boat of 3 months and you diagnose muscle invasive cancer on your first check cystoscopy after induction BCG of 6 cycles, you may find that you've already lost the window of doing a cystectomy after the diagnosis within 3 months. And this may prove disastrous. That's why a RETUR is important for high-grade non-muscle invasive bladder cancer, even though that you have sampled the muscle.
Right. And Dr. Hammad, would you also like to comment on the difficulty of getting our patients to understand why we're literally taking them back to the operating room after 2 weeks, especially in a patient like this who barely has the money to make up for his treatment? So there are a lot of logistic factors involved, because of which we end up missing this RETUR.
Yeah, so this is a problem that I'm sure Professor Prem and myself face on a daily basis, that finance becomes an issue once you, but then you should look at you need to sit down and explain to them. And it was only about 2 hours back when I was in the clinic, I was explaining a patient about the need for a RETUR because the previous one has detected a high-grade cancer, and I have to do the same thing, talk to them about what we can miss out. And so once they are convinced, then it is obviously, but some of them will not be convinced. So Prem, how do you make them understand?
Yes, I would like to add that for the residents, just about 8 to 10 years ago, when I suspected the cases with the ureteric colic or the urolithiasis, always I asked them to go for the CTQV. My seniors were blaming me, why you are doing the CTQV? Patient cannot pay it. It is very expensive at that time. But now in Nepal, probably there is not a single urologist who is not doing CTQV to diagnose in ER for the urolithiasis. Similarly, in this case, if, as Dr. Hammad said, if you counsel your patient properly, that what he is going to face, how is your graveness of the disease, how is serious his disease, if you counsel him properly, definitely that is not matter of the money. They will find out. You may use your charity program in the hospital, or you will find out some supporter. Definitely they agree. That is not the thing of the money. Yet definitely they are poor. Most of our patients in the hospital are poor. But if you explain them about the grave of the disease, definitely they will agree.
Totally agree with you. I'm sure Johor doesn't face these problems. Rich people, no problem. Yes, Hammad, carry on.
Right. So as the dose was asked about, so this was 120 milligrams per week for 6 consecutive weeks, and this is what constitutes the induction of BCG. Right after induction, soon after, and this is approximately 3 months from the first TURBT. And again, this patient fell into that unfortunate category who we were unable to convince to get a re-TUR within 2 to 6 months based on the high-grade pathology. So, however, approximately 3 months from the first TURBT, when we went into his bladder again, we saw 2 small scattered growths at the posterior wall. They had to be biopsied. Fulguration was done. There were small growths, and the histopathology this time around came out to be TA high grade plus carcinoma in situ. So residents, this patient was on BCG. He had an initial T1 high grade without any carcinoma in situ, and now he has a high grade pathology which has persisted, and he has gone on to show some carcinoma in situ. What do you think has happened?
Dr. Ahmed, one question for you. Which BCG you use in Pakistan for the installation in the bladder?
What's the strain? Yeah.
Which is strain BCG you do you use?
Dr. Hammad, can I divert this question to you?
We use Oncotice.
Onco
so there are 2 formulations. One is 81 milligram, which is the commonest Oncotice which is available. The one that we have is a 120 milligram Oncotice. This is a Turkish strain.
Is it your regular dose that 120 milligram you use?
Yeah.
Because in Nepal, we use only 80 milligram. Even with the 80 milligram of the BCG, the side effect of the BCG is so high, then we need to decrease up to 40 milligram also. 120 milligram is quite high dose for our people. Maybe the Pakistani people are more healthier than the Nepalese one. I don't know.
Let me explain. The formulation is such that this is equivalent to 81 milligram of the commonly available Oncotice. So this is the same strength of things, but it is not.
Milligram.
Yeah, it is equivalent to 81 milligram of the regular Oncotice, which is marketed majority of places. So there are over 12, 14 strains which are available around the world, and the concentration and the viable bacterial counts vary. So
right, that's what I was wondering too, because our strain is 50 milligrams, and because of the shortage, we were cutting it half into 25.
Yeah, so really the dose is you need to find the equivalence.
Okay, and for the Ahmed, my another question is, in a Cystoscopy, you could see 2 small bladder tumor. Yes.
Yeah.
Yes.
How you can say it is a recurrent or it is a residue?
It was
most of the TURBT is given to. We are here only the urologist. It is done by the residents. Most of the TURBT. So most time the recurrence we say mostly they are residual. Even if it is recurrent in high grade T1 high grade with the recurrence of the bladder tumor, the management option is obvious. I think residents should answer in that question.
So I think another important point raised that if you are interested in management of bladder cancer, you have to do your TURs yourself. I remember
that is very correct.
Yes. So in UK, I remember that the TUR and the flexi clinics were run exclusively by the registrars. That was the old practice when I was there. But TUR bladder is the most important part of the management of, and I totally agree with Professor Prem Gayawali that you cannot relegate it to a junior staff member. You need to take the responsibility. You can also make mistakes, that's not true, but it is something that in some corner of the bladder which was missed out and you have a tumor, remember, if you have an intact epithelium, you can put any type of intravesical immunotherapy or chemotherapy, it is not going to function. So a poor quality TUR cannot be replaced by intravesical treatment. So you have to resect completely the tumor.
That is true.
Right. Thank you, Dr. Prem and Dr. Hammad. Just a very small clarification. Dr. Hammad does not mean to say that residents at AKU do not do TURBTs. What he means to say is that the surgeon, once you all are consultants, just be in the operating room and see for yourself. Don't leave your trainees unsupervised.
For the
Right,
residents, TURBT is very much difficult than the TURP.
Agreed.
Small bladder tumor to resect is far more difficult than doing the big prostate TURP. You should remember this in your mind.
Yes, and can have far leading repercussions and consequences based on lack of experience, right? So, so a lot of people have already pointed out in the chat box that this is BCG refractory. What do you tell the patient? What do you want to do next? Residents in the chat box. Right, Dr. Zahra Kazmi says we do a cystectomy. Or we could repeat the BCG, right? Dr. Johar, what would you do in this setting?
So the other thing I would be interested in finding is the urinary cytology. That what is the cytology like? Number one. Number two, I want to look at the upper tracts because it seems like there was some questionable CT done in the past, and you're pretty, at least you're 12 months out. So I would like to look at the upper tracts, and prior to going back to the OR, I would have cytology available. If it is positive, I would do selective cytology as well from both the sides, do prostate biopsies because of this new CIS business happening. Now you have one of the two options. You could, because disease has not, with the CIS existence, you can argue that it has progressed, but it has recurred with lower stage compared to what you were previously. So you can argue about a reinduction, or you can argue about switching your agent. But unfortunately, because of the presence of CIS, I think your response rate will be pretty compromised. Therefore, like Dr. Zahra mentioned, I think cystectomy is one of the top management options.
Right. Thank you, Dr. Johar. So as rightly said,
sir, here is my different opinion. Once you have the recurrent T1 high grade, because the cytology in the bladder tumor, if it is high grade, the possibility of having the positive cytology is only 70%. It's still 30% of the cases you are missing with the high grade tumor. The tumor is recurrent and it is T1 high grade. I think we shouldn't waste time for the re-TURBT or BCG installation, thinking like the.
I think it was TA high grade. It wasn't T1 high grade, if I'm not wrong. The second
T1
pathology.
high grade. Yeah.
It was T1 high grade, but a high grade recurrence, irrespective of T1 or TA, on BCG is BCG refractory after 5 to 6 cycles.
And in second histopathology, there is carcinoma in situ also.
Agreed. Right. So we'll move on. So as per definition, this classifies as BCG refractory. At this point, you tell your patient the best management option for him in terms of disease control or cure is an upfront radical cystectomy. However, now recall the first slide for this patient.
Sorry, Ahmed, I'll stop you here because there is a question about chat box on BCG refractory disease. And Junaid wants to know that he's confused looking at the guidelines, how to approach. Now, Dr. Gyawali has very clearly explained that any experimentation with the patient is not a standard treatment. Remember that a BCG recurrent non-muscle invasive cancer is more dangerous than de novo muscle invasive cancer. So if patient has recurred on BCG, it's a BCG refractory disease, you need to be aggressive in treatment and you need to remove this bladder earlier than later. There is a very good paper in European Urology 2017 by Gangzer et al., which showed the delayed versus early cystectomy in patients who had BCG refractory. And if you delay your cystectomy, you probably rather not do it because it's not going to give real advantage to the patient. There is no role of new adjuvant chemotherapy in this group either, because if this patient is non-responsive, you have missed the window. So you need to be aggressive in the treatment. Now, there are patients who are not willing for cystectomy, and there are patients who are not eligible to have cystectomy. That is the group that we're going to talk a little later once you have progressed with your rest of the presentation. So this is your sharing with the EAU definitions of BCG refractory, BCG relapsing, and BCG unresponsive definition. They are a bit confusing, but you need to remember that if you have had a proper induction and maybe 1 to 2 cycles and you have a high-grade recurrence, that is the end of the story of intravesical treatment, and that is the beginning of the cystectomy surgeons to step in. So the patient goes to Professor Prem and to Johar for cystectomizing the patient.
Right. So Dr. Hammad did mention you have to know whether your patients are eligible for a cystectomy based on their overall status. And if you recall, this patient has new onset atrial fibrillation. This patient has such bad COPD that he experiences spontaneous pneumothorax. Furthermore, he is hyperthyroid. So he has a lot of issues going on. Now, we got him seen by a pulmonologist, and the pulmonologist had nothing short to tell them except to consent for the radical cystectomy with simultaneous consent for definite ICU, prolonged ICU stay, and a small chance of an on-table death. That's how bad his lung situation was. So I mean, that's a bit of a fix. And then what option do we have but to go to the next best would be, which would be to start with BCG all over again, BCG reinduction, right? So we proceeded with BCG reinduction, and unfortunately this guy was lost to follow-up. And more unfortunately, so this is a very common happening for patients who are coming to us from either resource-poor families or from far-flung areas, and maybe outside the country as well, mostly from Afghanistan. So he showed up again in May 2021. Fortunately for him, Dr. Johar, when he asked about symptoms, his symptomatology was still something that he was managing. He was living with it without a lot of hassle. He was okay with the hematuria. Had probably gotten used to it. So he came again, and we told him, listen, you've failed your BCG once. It's been refractory. We couldn't complete the reinduction. The max that we can do is just take a look inside to see. We took him this time with a flexible cystoscopy without any spinal or any GA. There was again, despite the previous fulguration, there was again a small recurrence. So whatever this field cancerization was, it was quite aggressive in his case, and his high-grade pathology has been persistent throughout. So this stamps his BCG failure. and unfortunately, he's not eligible for a cystectomy.
So, Dr. Prem, what would you do in a situation like this? When
Yeah, just I have one or two questions to Hammad before going for treatment, final treatment of this case. Why that patient was lost in before his last presentation? He didn't like the type of the treatment, or you couldn't do the radical cystectomy? Why he was lost?
So it was primarily because his treatment was being funded by a third party that was not related to him. And, it was a pretty sad situation. His married daughter would at times accompany him.
So it means the economical situation, he defaulted the
Yes.
treatment, yeah? That is
Unfortunately,
the main thing is
yes.
that you were emphasizing that because of his COPD, he could lie on the ICU for a long time. He may not tolerate this surgery. That is not true. In radical cystectomy, if your anesthesiologist is very perfect, you can do it very easily under the epidural anesthesia. You do not need to intubate the patient. Because you are working in the lower abdomen, pelvic organs, you can do under the epidural anesthesia. Only the thing is that if patient denies your suggestion to undergo the radical cystectomy, that is the another condition. So I would suggest him to go for the radical cystectomy, either under general anesthesia or under the epidural anesthesia. That would be my first choice. If patient refuses, you can explain him what can happen. And again, in the beginning, I said I do not rely very much in the repeated BCG installation. If BCG failure, then again you can go for the mitomycin installation or so on. But as good as the radical cystectomy, nothing will cure him.
Right.
I agree with Dr. Prem's suggestion. I haven't personally done it, but I've heard people doing radical cystectomy under spinal epidural combination. The other thing is that I think by looking at by the timeline, seems like he just got 2 doses of reinduction, and it has to be at least 5 out of 6 before you say that he has failed that. So he basically had inadequate treatment, and then the disease recurred. I agree with Dr.
Your
Prem
voice is interrupted.
if it is aggressive.
Your voice is interrupted. We cannot hear you.
I do agree with doing this under spinal epidural combination. And that would have been my first to go once the pulmonologist said about the pulmonary complications. The other thing is that he just received 2 treatments out of 6. So you have to have 5 treatments out of 6 to confirm that you have actually failed the BCG therapy. Just an FYI. But again, I do agree with being more aggressive.
Dr. Johor's first induction was complete, 6 out of 6, and then 3 out of the next 6.
Oh, it was 3. Okay. It seemed
Yes.
like 15 and 31. So that's why I thought.
Right. So 15th and 22nd and 31st weekly.
Okay.
My bad. I should have made that more clear.
So the patients who have significant morbidities and anesthesia time is crucial because they can have complications. One of the easiest ways to try and decrease the surgical time by doing the cutaneous ureterostomy. So I have done patients on epidural anesthesia with cutaneous ureterostomy. The whole process doesn't take more than 2.5 hours. And these patients do quite well, actually. And 2 of them are there for about over 7 years now in my practice. Not a big number, but yes, that's a possibility. So if you have a very good anesthetist and if you have good perioperative care, then even general anesthesia is a possibility. So the risks are there, but then it's not. In modern day, it's like chemotherapy. The oncologist would give as long as they can maintain an IV line. So in modern day practice, anesthetist can take care of any patient, and they do in dire situation.
Okay, right. So
I think we should not go to the case number 3. So, I mean, it's more theoretical. It's something that I would not really suggest in majority of situation. But those patients who refuses cystectomy, you have a few options available, although these options are certainly not very commonly exercised, particularly our part of the world. And there are 2 good quality studies showing the role of immune checkpoint inhibitor pembrolizumab. And this was FDA approved January last year for patients who either refuse or are not fit for cystectomy, and they have BCG refractory disease. So you can either use an immune checkpoint inhibitor. You need to check for their PD status. So the PDL expression needs to be assessed, and if they are positive, it means they're going to respond to the immune checkpoint inhibitors. The other one is a very exciting new drug, which is called the nadofaragene Photodynamic. Now, this is an exciting new thing, but again, it's very expensive, and it is not easily available, and it is very new. And we don't have very strong, long quality data at the moment. They use a virus vector to insert gene within and then intravesical installation. So these are some of the things, and there are some other way of putting new chemotherapeutic agents, etc., etc. So there are a lot of things that you can do, but no good quality data that they can replace the outcome of oncological outcome of cystectomy. Okay. So I think we are 8:45, and it must be 10:15 in Kathmandu. Time for Dr. Prem to have his dinner and go to bed for an early morning work tomorrow.
It is 9:30 in Nepal.
Oh, 9:30. So it's a half-hour difference between us. Yeah. So great. I'm really grateful to Dr. Johar Raza, to my dear friend Prem, for being here and to help our resident clarify a lot of very complex issues. It is a complex disease, and you need to really be upfront in making your decision. And these kind of interactive discussions are really helpful. So thank you again, and have a very good evening. And thank you, Hammad, for so nicely presenting those cases.
Thank you, sir. Good night.
Thank you. Good night.
Thank you, sir. Thanks for the opportunity.
Thank you, everyone, for
Thank you.
joining. Thank you, Dr. Hammad.
So tomorrow we got another exciting day, and we are going to cover urethral stricture. We are going to cover urethral stricture, and we have Madhu Agarwal from India. We have Professor Manzoor Hussain from Karachi talking about stricture disease, how to make decisions, and how to use imaging to make good decisions by Madhu. Then we have 3 presentations on interventional treatment for BPH, and we are going to introduce, talk about what is the current gold standard in terms of BPH, either it is HOLAP or TUR, and then some of the new thing which has come up just for you to know, because they can be part of your TOEFL examination and nothing more. So this will be covered by Tariq Sami from UK, from Aninda from again UK, and in between we going to have some very interactive cases on andrology, 2 on erectile dysfunction, and 2 on infertility. So see you again tomorrow, starting off early at 5 o'clock. Until then, take care, good evening, Khuda Hafiz, and Namaste.
Namaste, good night.